Good evening. Welcome to session 13 of the SCTS Foundation Doctor Academy teaching series. I'm honoured and pleased to be joined by Ms Lisa Carson-Price, who's a Senior Clinical Perfusionist at University Hospitals of Leicester. And tonight she'll be talking to us about Cardiopulmonary Bypass, a much awaited talk.
Thank you very much. So normally when I deliver this lecture, I like to sort of bring people into theatre because it's always easier to show you what I'm talking about. But that's not possible tonight. So hopefully I am going to bring a bit of cardiac theatres to you. So a little bit of background, because I'm not sure where you're all from, what exposure you've had to cardiac surgery. So as you probably know, the cardiac surgery is the treatment of injuries or ailments of the heart through incision manipulation and using a series of instruments. And again, just really a bit of background and reference, really. So when we're talking about cardiac surgery, I'm going to mainly talk about adult cardiac surgery because the plethora of operations there are in paediatric surgery is immense. So we'll keep it simple and we'll talk about sort of the adult surgeries. Now, 90% of the adult surgeries are going to be covered in the next couple of slides. And like I said, it's more for terms of reference, probably read up and have seen some of this, but at least we're kind of singing all from the same hymn sheet. So the first kind of surgery we see is coronary artery bypass grafts, which is basically bypassing any blockages in the coronary arteries, and that can be used venous vein graft. We can use internal mammary arteries, and we can also use radial arteries. And the choice is dependent on the surgeon preference and the state of the patient, really. The next thing we go on to is open heart surgery. So it is, as it says on the tin, is when the atrium or the chambers of the heart are opened and we either repair or replace one of the valves. Now, the decision to repair or replace will depend on the disease process, but I'm not going to go into that because it's a whole lecture in itself. And the surgeon has a choice whether to use a mechanical valve or a biological valve. And there are pros and cons for using both. So biological, the main thing is for the patients, they don't have to take warfarin. So no tablets, and they can have a drink if they like to do so on a Friday night. Or with the mechanical valves, they last a lot longer. So the rate of reoperation with the biological valves is it basically lasts a lot shorter time period. And then we come on to aortic reconstruction. So these are sort of your biggie operations, the longer what will come on to bypass time operations. So it can involve the aortic valve, or it can just involve the aorta. It can be the ascending aorta between the valve and the head vessels, or it can go all the way around and include the vessels to the head as well. So we've really touched, like I said, because these are 90% of the surgeries in the adult world revolve around correcting or involving those clinical areas. So sounds good, I suppose so, but how is it achieved? Well, all of them, apart from coronary artery bypass grafting, is, like I've mentioned, open heart surgery. So we need to go into the chambers of the heart. Now, if we do that without the heart-lung machine or the cardiopulmonary bypass machine, we either will exsanguinate the patient or we will entrain air into the patient, neither of which we want to do. With coronary artery bypass grafting, yes, it can be done off pump or not using the heart-lung machine, but it's much more difficult because if you think you're stitching onto a moving target with bleeding points, so it's more difficult to see. So a lot of surgeons choose to do coronary artery bypass grafting on pump or using the heart-lung machine because it provides a still bloodless field which the surgeon can operate on. So, and the reason surgeons decided to move away from using the cardiopulmonary bypass machine to do this procedure is because they thought it was better for the patient, in the fact that the immunological response would be much less. But actually, as time's gone on, and this kind of, if you like, it's a bit of a fashion really, came about and realised it's not the heart-lung machine that produces a lot of the inflammatory response and activation. It's actually the mere fact of opening the chest, opening the pericardium, exposing it to air. So the real benefits of off-pump surgery are not really what we thought they would, but there are still some surgeons that still persist with it just because neurological implications seem to be slightly better, but that's something we'll touch on later as we go on. So what is coronary artery? What is a cardiopulmonary bypass? Put my teeth in. So what is cardiopulmonary bypass? Well, basically, if you think about the heart and the lungs, it is basically a circuit. And, you know, perfusionists are technicians, so we talk about circuits quite a lot. And it involves the pulmonary system and the systemic system. So the pulmonary system returns deoxygenated blood to the heart, so it can pump to the lungs and be oxygenated. And the systemic system, well, the heart then pumps the oxygenated blood to the tissues around the body. So it's a complete system. Now, cardiopulmonary bypass, what we do is basically we extend that system. So we put a pipe in an artery and another pipe in a vein, and we're basically expanding that system. And what that does, it gives us the opportunity to bypass or do the job of the native heart and lungs. I don't know if anybody can hear me. I hope you're following okay. I can't see anybody, so I hope all's going well. So here we go. So what is perfusion? Well, I'm a perfusionist, and basically perfusion comes from the word perfuser, which means to pour over or through. So basically all we're doing is using technology to perfuse blood and oxygenate it and pass it through the tissues, pass the fluid through the tissues, through the vessels, into the organs and tissues. Right, the nitty-gritties of the talk. So literally I wanted just to touch base because, like I said, I didn't know what people had been exposed to and what they had seen. So what I'm going to talk about is cardiopulmonary bypass, the circuit. So we're going to talk about circuit components. We're going to talk about prime, which is the fluid put in the pump. We're going to talk about cannulas, and we'll talk about a few cardiopulmonary bypass techniques. So here we have down here the cardiopulmonary bypass machine. The main components really are an atrium or a reservoir, which is sat down here somewhere. You have a pump, which will do the job of the heart, an oxygenator, which does the job of the lungs. So those are the three main components. On top of that, we have lots of suction devices here, which basically minimises the amount of blood loss that the patient experiences. So it almost gives us an opportunity to recycle that blood and help prevent or helps the surgeon see where they're doing, because we talk about things called vents. Now, vents can go in various arteries, so it can go in the pulmonary artery, it can go in the left ventricle, and basically what we're doing is sucking the blood away from where the surgeon is operating so they can see what they're doing. We also have a heater cooler, which attaches to our oxygenator, which gives us control of the patient's blood temperature, so we can either warm or cool the patient. And you'll see quite often that actually we use that as one of our tools and techniques during cardiac surgery quite a lot. So these three things, the reservoir, the roller pump and oxygenator, they're basically put together by a series of different lengths of tubing, making our circuit that we talked about earlier. A little bit more in depth then. So if you were in theatre, sat with me now, this is what I'll be talking to you about. I'll be pointing these out to you. So here we have our heart. Now this is called a roller pump, and it basically uses peristaltic motion and pushes fluid around the circuit from the reservoir into the oxygenator. And this is what it looks like. And here you'll see the flow. Now we'll come to talk about patient flow shortly. This is the reservoir. And again, depending which hospital you go into, which, you know, there's a range of manufacturers out there, but they all do the same thing and they all really have the same components. So in there is what we call a screen filter that will remove anything, any debris from the circuit that return from the patient, from the circuit, any large clots or anything like that would be caught in there, if there were any, of course. And then here we have the oxygenator. So in the oxygenator, you see water lines at the back, and here is where we can either, we have, if you like, a radiator inside there, where cold or warm water passes inside that radiator, and as the blood passes over that, the patient's blood is either warm or cold, giving us control of that. And like I've mentioned earlier, these things are connected with a series of tubings. So a little bit more in depth. So again, I can tell you, I'm going to show you what we do, but I don't want to tell you just what we do at Glenfield or at UHL. If you go to another hospital, it will look completely different. And that's because certain centres prefer to use a different type of pump through experience. And let's go back a moment. Through their experience and clinical practice, they will choose a pump. Now, the two that are currently on the market, and again, I'll get right back to the point. Oh, gone past it again. There we go. So there's two types of pump on the market. The one I've talked about and the ones that's most commonly used in the world is the roller pump. That uses peristaltic motion that presses the tubing, compresses the tubing, and pushes blood round the circuit. The problem with this is you experience something called spallation, where particles of that tubing can break off into the circuit, which isn't great. Hopefully there are filters in the system that will catch this. The other thing is, if you think about that roller pump pressing on the components of the red blood cells, components of the blood, red blood cells, platelets, so on and so forth, if it's for a short term, it's not a bad idea. But if we're talking, longer bypass times, over time, all those components will be affected by some degree of damage. So it's not ideal. So then we come to the centrifugal pump. Now, the centrifugal pump is often considered for use when your bypass is going to be longer than 6 hours. Now, in most cases, if you're talking about coronary bypass grafts or an aortic valve, really you shouldn't be on bypass for anything longer than 2 hours. However, some people choose to use this routinely because the nice thing about this is there's no compression of the blood components, so you get less damage, less hemolysis, less damage to the clotting factors, so on and so forth. And also, most of these, if we look at this component down here, there is what we call very few fixed seals or bearings. So there's very little heat generation. So you don't tend to have a lot of clot formation in these areas. Excuse me, I'm getting over from flu. So the benefits of this are quite good. The problem is this component is very expensive. So while with this option, the roller pump, it's a bit of tubing that probably costs maximum £30 to push around. This, you're talking anything between, depending which one you use, probably 60 and several £100, and 60 is being if you've got a very good deal. So actually it has a significant cost. And because, like I mentioned, most of the surgeries should be relatively short, the benefits you see between these two are probably not really seen so much in cardiac surgery. So when you're choosing a pump, the main thing you need to look at is the wide range of flow, because if you're like us, where we do adults and pediatrics, we need to make sure that our flow ratings go from 100 mils all the way up to 7 litres, because for a big person, or a very fit bodybuilder, you may want to get up to 7 litres. And as I've mentioned here, low hemolytical effect, so not damaging the components of the blood. And I suppose one other thing is the simplicity and safety of use. So they've got to be safe. And that is why you routinely see in a centre they replicate what they have in one theatre with all the others. It's the safety thing. So another major component, the oxygenator. So this basically does the job of the lungs. So what it does, it acts as a semi-permeable membrane. So the fibres in there, which you see here, are made from polypropylene fibres, and they act as, like I said, a semi-permeable membrane. So what you do is you have high oxygen content on the gas side, you have low oxygen content on the blood side, and it diffuses across, and CO2 moves the other way. So you have high CO2 on the blood side, low on the gas side, and it diffuses across, and out of the exhaust. So if we need to increase our oxygenation to the patient, we're realizing from our monitoring that we haven't got enough oxygenation, we increase the blood flow. So we turn our flow up. I'm going to talk a bit more about flow later on. If we need to remove CO2, we can basically increase our sweep flow. So it's very much like having a ventilator on our machines. So, like I said, when you come to set up a heart-lung machine, first thing we come to set up, when we come to set up, we need to check the hardware. So you have the hardware and you have the disposables. So this is the pump configuration we have at University Hospitals Leicester. And like I said, if you go and look at any other hospital, they will differ because it will differ on the position of the pump. So we have our pump opposite the surgeon. In other centres, they will have the pump behind the surgeon or the consultant surgeon. At other centres, they will have the pump at 90 degrees. So the orientation will depend on where the pump is positioned and what the centre chooses to use. So here we have what we called single-headed pumps, and these are smaller, what we almost call double-headed pumps. So here we have our arterial pump. These will be our suckers. We have Cardioplegia and more suckers. If you look on here on there as well, we hopefully should recognise this. So that's our anaesthetic gas, which we can put through our oxygenator. This is what we call our gas blender, which is basically the ventilator, and the old-fashioned, the CPB gas blenders before the modern versions here. So we get our disposables, we get our hardware, and we plug it in, and we check that the lights come on and the pump's turning in the right way, and then we're ready to set up our disposables. Now all our disposables come up in packaging like this, so it's all sterile within there, and we put it together using aseptic technique. So we check the packaging, open it up, and it comes in the packaging like this. We then locate the main component. So do you remember what this is? So this is our reservoir. We then have our oxygenator, and we put the tubings round the raceways in the appropriate fashion. Now, when we're making our connections, like I said, all the inside of the tubing is sterile. Now, obviously, it can't be 100% sterile because we're opening it to air. But when we make the connections, what we do is we use a technique like this to make the connections. So the inner bit of the tubings will never touch anything unsterile. So we slowly push it on, and that is called an aseptic technique or an aseptic connection. Now, I'm sure you've realised on this circuit there are a lot of connections, so it does take a while to do. And I've got to profess that our circuit at UHL is, should we say, pretty heavy on the connections. We've got a lot going on. So there's a fair few of those to do. But usually it should take us no more than 15 minutes to make all those connections, put the tubing in the right places, the oxygenator and the reservoir, and what we call our water lines here at the back. And there you have our end result. So if we were talking about, if we had this in theatre and we had our fluid running, what you would see was fluid taken from the reservoir being pumped around the pump here. So remember, this is our heart, into the oxygenator and our at the back. That would then come around here, which into the tubing around the back there, which is the lines will be handed up to the operating table and connected to the patient eventually. So this would be turning. You can see a flow rate of 1.82 litres, and you would see the fluid moving. It's very difficult to show clear fluid moving around a circuit on a video because you can't really tell the direction. But I've got another picture later with blood in it, so hopefully that will help. So I've talked about the hardware, I've talked about the disposables, and I'm now going to talk about some of the other components that you've seen. So we've got a lot of, technology going on. So as part of our monitoring, we have a device that has constant inline monitoring of our arterial gases. Now, if you think about basically the aim of the game of a perfusionist or, the heart-lung machine, it's basically to ensure we're oxygenating the patient, and that we're trying to, as much as possible, normalise the patient's blood values. So if you look, this is what we call a CDR monitor. So we monitor our arterial saturations here, and then we have a cuvette on here, which measures our venous statistics here. So this is our arterial shunt. So some of the blood from the oxygenator bypasses through here to measure that. And with the venous side, it's a clip that flashes a light through a sensor, and it picks up this information here. The other thing that we rely on heavily is this thing down here. So this is your ACT machine. So I'll talk a little bit more about that in detail as we go on. So before we put a patient on bypass, we have to anticoagulate them. And the reason we have to anticoagulate them is the body's automatic reaction to going on to bypass is to try and clot, because it's an invasion, isn't it? We're opening the patient's body and the automatic reaction to clot. So we need to overcome that. Now, your normal activated clotting time can be anything between 80 and 120 seconds. So the prerequisite for going on bypass is 400 seconds. And we maintain activated clotting time of 480 seconds. So, because basically, if the circuit clotted off, we'll be able to push the blood through the circuit and oxygenate it. So it'd be game over. So just a few more of the components that you've seen on the diagrams, in case you're wondering what they were. So I've mentioned prime. So basically, when I talk about prime, is we need to put some fluid into the circuit. And the reason we have to put fluid into that circuit is because when we connect our circuit, we're going to connect the heart-lung machine to an artery and to a vein. Now, if it's not primed, we will basically pump the patient full of air. And again, obviously there's no point in continuing with the surgery because we're essentially, killing them. So we use a range of fluids to displace that air. Now, historically, if you've seen some of the history of the cardiopulmonary bypass, the heart-lung machines were primed with blood because they were huge things and the dilution effect was massive. Now, because our circuits are so much smaller in this day and age, so for an adult circuit, the priming volume or the amount of volume it takes to fill that circuit is 500 mils. We don't need to do that anymore because 500 mils in an adult, your average size adult, is not a biggie. When we talk about pediatric surgery, yes, we do use blood, but we use significantly less amount. But like I said, I'm focusing on adults today. So prime, again, depending which centre you're at, there is a degree of variation. You tend to always find there will be a crystalloid, a colloid, and heparin. Those are kind of a given, but depending on their preference, the anaesthetic input, the kind of cocktail will differ slightly. So what we use for our crystalloid component to UHL is Plasma-Lyte 7.4. The reason we use it is basically because it's pH normal. So we're trying to make it as normal for the patient as possible. We don't want to, we're trying to avoid, a massive shift once we connect the patient up to our heart-lung machine. Now, Plasma-Lyte is more expensive than your Hartmans or your Ringers or Saline even, but other centres do use that, but we like to try and maintain our pH as much as normal. We then use Volplex. So again, in other centres, they may use Gelfusion or so on and so forth. And some places that may even use albumin, but there's been a kind of shift away from using albumin, and it's mainly used in paediatrics. And the reason you use something like that is basically you want something that's got a big molecule, because we're trying to prevent a fluid shift. Because if we otherwise all the fluid will move into the patient and cause an edematous reaction. So if we put some big molecules in our prime, with the aim of the game is to try and prevent, as soon as you can bypass the fluid shift into the tissues, which makes patients all boggy and so on. We then add heparin. So I mentioned about activated clotting time in the last slide. So we want to try and avoid patient clotting because we can't otherwise obviously push that patient's blood through our circuit. So we will add 10,000 in our pump. Let's go back a moment. We'll put 10,000 in our pump, and the anaesthetist will also give a dosage, which we'll come to again shortly. I've lost my slides. There we go. So the other thing we use is mannitol. So there's a big debate whether you should actually put this directly in your prime before you go on bypass, or should you drip it in as you actually on bypass. So the reason we put mannitol in is numerous reasons. One, it acts as a diuretic. One of our sort of markers to know whether you're perfusing the patient appropriately is to check whether the patient is passing urine. Now, mannitol is a diuretic, so it helps the patient pass urine, so we can almost encourage the patient a little bit in that side. However, it also acts as a free radical scavenger. So when we talk about free radical scavenging, if you think about the Krebs cycle, go back to basic science. If we undergo any anaerobic respiration, which we will do because cardiopulmonary bypass involves a period of time when the cross clamp is on, so this is when the heart is ischemic, and during that time there will be a degree of anaerobic respiration. It hopefully will mop up any of those nasty free radicals and prevent damage to the organs. And then the final thing is a little bit of bicarb. And again, some centres choose to use this, sometimes some don't, sometimes some don't. And so therefore, you know, we try to prevent being acidotic, so we do add a small amount. So I did mention earlier that actually the oxygenator, the priming volume, if you like, is about 500 mils. By the time you've got all the tubing and everything else, it's actually more. It comes to about a total fluid addition to the patient of 1.5 litres, 1.4 litres. In some centres, it's as much as 2. But again, to an adult patient, this isn't a massive big deal. So, cardioplegia. So, cardioplegia is essentially the stuff we use to stop heart. So I mentioned earlier, you know, the aim of the game when we're doing using the heart-lung machine is to provide an extension of the patient's own system. But the other thing I mentioned was talking about stopping the patient's heart to provide a still and motionless field for the surgeon to operate on. So we basically do that by arresting the heart. So if we put a cross clamp on at this stage and we arrest the heart, it will also protect the heart. So we stop the heart, it reduces the metabolic demand of the heart cells by about 80%. We then give cardioplegia with oxygenated blood, and that gives about another 5-10% of the native oxygen demand is given in that blood. And then it's given very cold, so it's given at 7 degrees. So that hypothermia again on the heart will reduce the metabolic demand of those heart cells. So it's about maintaining the balance, the metabolic demand of the heart from an oxygen point of view and supply. Now the main solution of choice in this country is St Thomas's #1 solution, and it basically works by producing and preventing repolarization of your resting membrane potential. So it's got a lot of potassium in it. It fluxes in, if you like, and it prevents this repolarization of the heart cells. There are plenty of other solutions on the market. Some are more common in other countries. So there's Del Nido and Custodial, where you give one shot, and there are some benefits. But the predominant one, and the one that seems to work well, is the St Thomas's #1 solution. So I did mention very quickly on the previous slide how it works. So this still heart, that's stopped. So we're going to put a cross clamp on. So there's not going to be no blood going to the heart. So we need to protect it, like I mentioned. And we do that by mixing the cardioplegia solution, so in our case, St Thomas's, with oxygenated blood from the oxygenator. So we do 4 parts blood and 1 part cardioplegia. Now this can be done in a number of ways. You can have this tubing 4 times bigger than that. You can have this pump turning 4 times quicker than that. So there's loads of different ways. And also, as the blood passes through the heat exchanger, we're going to give it cold, like I mentioned. So we're protecting the heart by lowering the heart's metabolic demand through cardiac arrest, so reducing the metabolic demand of the heart by about 85%. By cooling it, again, reduce the metabolic demand of the heart cells by about another 10%, and then providing the oxygenated blood, which we will give every usually 20 minutes whilst the cross clamp is on. So a little bit more about cardioplegia. So cardioplegia, like I said, it's stuff that stops the heart, and depending on the surgeon and depending on the operation you're performing, you can either give it antegrade or retrograde. So antegrade basically is, I call it forward, and retrograde is backward. And I suppose the main difference between the two ways is retrograde, the backwards one, is going into a venous side, so it's a low pressure system. And antegrade is going into an aortic or an artery, so it can be directly into the artery, up into the aorta, or down the left or right coronary artery. So it's used to a much higher pressure system. So again, like I said, there is lots of debate on whether we should give it antegrade or retrograde, but it really does, I think the predominant choosing factor is the surgeon's preference. And some believe in doing both, because if you have somebody with coronary artery disease, for example, and you got a blockage here, if you're giving antegrade and retrograde, you can ensure a more global kind of delivery of that cardioplegia. So, prior to, gone past it again. So I've mentioned about activated clotting time and heparin. So I'm trying to follow the steps, and I'm hoping it's making sense, of the process we do before we actually connect the patient up. So we have we've checked our hardware, we've put our disposables on our heart-lung machine, we've primed our heart-lung machine, so got rid of the air out of it. And now we're at a stage where we feel like we're at the ready. So at this point, hopefully the anaesthetist is just putting our patient to sleep, and then once the patient is in theatre, we would then think about anticoagulation. So as I mentioned earlier, the anaesthetist will give an amount of heparin. So they use 300 to 400 per kilo, and we have 10,000 in our prime. And again, this will vary from centre to centre depending on their protocols and depending how much the anaesthetist will give. But this is what we use at UHL. So if you're actually in theatre and you're sat next to me, the things you would hear is, can we have the suckers on? So you know those suckers I mentioned that are going to mop up the blood from the surgical field. Well, we can turn them on at 250 seconds because we know that there's only going to be a small amount of blood that's going to be sitting in our reservoir. You remember the reservoir that has some heparin in it. However, we won't go on bypass till the ACT reaches 400 seconds. Or actually, the old school way of doing it used to be 3 times the baseline. So we do baseline ACT once the patient comes into the anaesthetic room, which, like I said, should be anywhere between 80 and 120 seconds. But you find most centres and their protocols will have a set figure now, so it doesn't give any leeway for for any interpretation. It's 400 seconds, that's it. And once you're on bypass, it's 480 seconds. So basically, the main thing you need to know is that heparin works by inhibiting. Where are we? If I move, I'm not sure if I'm in your way. By inhibiting clotting factors, thrombin, thromboplastin, and prothrombin. Now, this is a whole essay in itself, so I don't want to bore you with that. We're supposed to be talking about, me bringing the cardiac theatre to you. I suppose the other thing that I need to mention before we actually talk about cannulation and connecting the patient up to the heart-lung machine is we've checked our hardware, we put our disposables in, we've primed the circuit, we're checking about ACTs. The final thing for us is our safety tools, and we have a checklist. I'm being click happy again with my my slides. So, and this is really important. And sometimes you'll find this is the time that perfusionists, because us perfusionists love to chat really, that if we're being a bit silent and deadly, it's usually because we're trying to concentrate on doing this. So we will be checking all our theatre equipment works. We are checking things like one-way valves being in the right way. Now, one-way valves are attached to those suckers or those vents that we popped into the patient to help improve the surgical field by reducing the amount of blood in the area. Now, if we put a vent or a cannula in the left ventricle, we were trying to suck blood out of it so the surgeon can see what they're doing, but accidentally we reverse the pump, or we put the tubing in the pump the wrong way. So when we thought it was sucking, it was actually blowing. It's going to pump air into the patient. Now, this is a catastrophic event. You know, this will kill the patient. And it has killed patients in the past. So we have these things that have one-way valves. And as part of the checklist, the rotation of the pumps will be checked. These one-way valves will be checked. And we do what we call a suction test, which you'll see down here, which we will dip it in some fluid to check it is going in the right way, because unfortunately, this has been a thing that has caused many fatalities historically. The other things we have on the pump are what we call a level alarm. So if our reservoir, you know, that atrium, that storage of blood goes too low, it will alarm just to warn us there's a problem. What could be a kink? The surgeon could be leaning on the line, because if we let this empty and we let our pump continue to circulate, it will eventually pump air into the patient. On top of that, we also have what we call a bubble alarm. So if any air did get to this point, which is at the bottom of the reservoir, we've got plenty of time to deal with removing the air from our circuit before it gets to the patient. And we also have another bubble alarm on our Cardioplegia device. So basically, I'm saying we've got a checklist. So a bit like a pilot, before they take off, they have a distinct checklist. We usually check the fluids and everything else with another member of staff. So there's double check safety mechanism, and all those things are supposed to be signed off by the anaesthetist surgeon at the end of the case, so we know that they are happy with them. We are sole practitioners, we are sole responsibility. If there's an error, obviously it's our registration that's at risk, which is why we have the checklists and the safety devices, because at the end of the day, it's not a nice thought that you can be in that sort of situation. Anyway, moving on. So before we establish cardiopulmonary bypass, we need to think about attaching how we're going to attach the circuit to the patient. So before we need to do that, we need to find out the patient's height, weight, and think about what procedure they're going to undergo, and how we're going to gain that access. So I'm going to go on now and talk and show you some pictures, hopefully, of the how we go about this process and some cannulation. So once my circuit is ready and I have done my checklist like I showed you previously, I would then go into the anaesthetic room and get the patient's details if they're not already in theatre. And the one thing we go to is the patient's notes, and we look the top three things are height, weight, and hematocrit. And the reasons we need to know that is because we need to work out our body surface area. And why do we need to know our body surface area? Because we need to work out what flow, so our arterial pump, if you remember rightly, how quickly we need to make it turn to ensure we give enough oxygen delivery to the patient. So I mentioned earlier a little bit about temperature. So the flow we deliver will depend on what temperature we're going to cool the patient down to. Now, more and more in this day and age, more and more surgeries are done warm, primarily because if we cool the patient, usually what we find is that the enzymes become deranged in your clotting factors, in your clotting cascade. So then when we warm the patient up, not only has the patient undergone surgery, so on and so forth, but we've also messed with the enzymes in the clotting cascade, which isn't going to help with our bleeding issues. So more and more surgeons will try to do things warm. The reason why surgeons may want to cool is to provide a degree of protection for the brain or for the spine, depending on the type of operation you're going to do. So if you're going to do an aortic arch, which I think I mentioned earlier is a long operation where you might need to operate on the head vessels, you might actually want to stop the circulation while they do that sort of operation. So we can do that, but we need to protect the patient by cooling them down. So it gives us you know, if you think about metabolic demand of the body again, which is, you know, an oxygen demand of the body, hypothermia, with hypothermia, you need less oxygen. So we kind of use that as a tool. We used to use it a lot more, I should say, but like I said, there's now more of a trend to do as much surgery as we can warm. So if we look at this chart up here, this is something we've devised at Glenfield. So we get the patient's body surface area, and we know our oxygenators that we use are pretty efficient in this day and age. So when we're warm, we know we can get away with a cardiac index of 2.4. So I've gone into the anaesthetic room, I've got my patient's height, which is 173, he's 101 kilos, and had predicted hematocrit of 44%. Now, why do we need to do that? Well, we're going to put lots of clear fluid in our prime. We need to know if this is going to be have a massive impact on the patient. Now, this patient has got a really decent hematocrit or HB of 44. So our prime total circulating volume, so prime and patient, has gone from 5.3 to 6.9, and his hematocrit on bypass is 34. Now, for the average patient walking around, you'd go think, oh my goodness, that's not very good. But actually, anything above 21% really is acceptable on bypass. Again, there is a push really to have higher hematocrits, but you rarely see a patient come off bypass with a hematocrit of above 30. You know, that would be your ideal. Anyway, so I think my point is to this is when you're documenting or if you're clerking in your patient, please, please, please make sure this information is in there, because we find it very important and very useful, and it causes all ends of problems if it's not in there. The other thing we want to know is the history of the patient. So here's our pump chart. In fact, this is one I've done today. So we like to look at what they've had done before and what other things they've gotten on. So for example, if this patient had something called carotid bruits, where they have atheroma in their vessels in their carotids, I would ensure whilst I'm on bypass, I would have a much higher perfusion pressure, because I know they've got obstructions in the neck into the head vessels, and to make sure the brain is perfused, I'd want to make sure the blood pressure is much higher than what I'd normally have on bypass. If the patient's got renal dysfunction, again, you'd like to know these things because we've got a way of doing hemofiltration on the bypass machine. So all these things are really useful. And the other thing we want to look at is the drugs. So we know if anything they're going to have an effect on what we're doing. So if the patient's been on warfarin and warfarin's not stopped, that's a signal to me that I am probably going to need some sort of extra suction device or a cell saver, because this patient's going to bleed. Again, if the aspirin hasn't been stopped, or the clopidogrel. So if you look on this patient here, I look through the notes, he'd had clopidogrel and aspirin, and there was no note of it being stopped. So if it has been stopped, please write it on there. It's very useful for us as perfusionists, so we know what to get ready for the patient. Anyway, I digress. So we're going to move on to arterial cannulation. We've only got 5 minutes. So this is the aortic, where we're going to put the aortic pipe in. So the arterial cannulation is as follows. So I'm bringing my theatre to you. You're looking over the top from the head of the patient over the top. Let's go back a moment. This little play for us.
Can you see anything? Yeah, sure. I think you've got to capture your finger there. Can you see? Yeah.
So here, the surgeon's got the aortic pipe in his hand. He puts a small incision in the hole. There we go. And he's going to push that pipe in there.
Can you see anything?
I'll fast forward it a little bit. And you can see here, the aorta's been cannulated. You can see an arterial swing here.
Yeah, yellow.
And the arterial blood is coming up there. And what he will do is now take out the stylet, which is basically a stiffening rod of the cannula, and he's going to connect it up to the bypass circuit here. Making sure, so he's tapping away there to make sure there's no air in that line. The perfusionist will push volume up there. And that's so that's your arterial connection. So moving on to the next one. So your venous cannulation or your venous connection. So it can be done in one of two ways, depending on what surgery you're going to undertake. So if you're going to undertake mitral surgery, you will need access to the mitral valve, probably through this region here. So what you will do is cannulate the SVC and the IVC and join them together to produce your venous drainage. So your deoxygenated blood will drain from there to your reservoir. If you're doing cardiopulmonary bypass grafting, because it's not so significant to get through this bit, you can use, or an aortic valve, you would use what you call two-stage cannulation. So one single pipe that has holes here and here to drain. This is more time consuming because it's 2 incisions and obviously more to repair after the fact. So very quickly play it.
Yes. Now I need the long knife, don't pull on that. I need the razor up to that and the curve.
So it will do the same technique again. So that's the SVC. Small knife incision. He's put his finger in the hole. He's now going to push the cannula in. Now he's going to make that hole a little bit bigger with the scissors. And I'm going to fast forward this a little bit because we haven't got much time. And he's being a little bit slow. He's struggling to get it in. He's trying to get it in the right position, so the right angle is in the right position. He's trying to fill with his hand here. He's happy.
Thank you. Thank you. Thank you. You'll be so I'm a bit like.
So you'll see
I'm going to be on
one line here, one line here. And he's connecting the 2 pipes together. So this is the tubing from Heartland machine. And we're connecting it up to the patient. Okay. So then I mentioned the aortic root cannulation. So this is where we would give cardioplegia. So here's our aorta. The aortic valve is sat around here. And what we do is we attach a needle into the aorta here. And it gives us the opportunity to both suck and blow, if you like. So we can give cardioplegia in one direction. And when the cardioplegia is finished being delivered, we can actually suck the blood away from that area so the surgeon can see what he's doing. So the needle's gone in, we've bled the blood back, and we will connect it up again, making sure there's no air in that line. So once all the pipes are in, this is what it looks like. So if you're standing at the top of the table where the anaesthetist is, here's your aortic line, here's your venous line, and here's your cardioplegia line. And I've got a sped up video of the whole thing here. Is it going to work? Oh, I think we might have to pass on this. I can send that video around to you. It takes too long for me to sign it. Anyway, so we've done our arterial cannulation, we've done our venous cannulation, and the final stage is after building all that process is to go on bypass. So if we look here, the key thing is your drainage or your deoxygenated blood is going to drain into our reservoir, so our atrium here. is going to get pumped by the heart here using a flow of 5.1 litres, because it's our patient from earlier, that's 100 kilos, and it's going to get pushed into the oxygenator at the back, and from the oxygenator at the back, the oxygenated blood will be returned back to the patient. So there we go. There you go, nice dark blood there. Slowly filling into the reservoir. Bit nice and dark, and the important thing is the oxygenated blood going back. I think another thing that's important to note is that the communication that goes on. Obviously, I can't see what's happening at the table, and the surgeon can't see what's happening down here. So we're constantly communicating, telling each other what's going on. So he tells me what he wants, I repeat the instruction back to him, and when that instruction is achieved, I confirm it by saying it has been achieved. So he said go on bypass, I said going on bypass. Once full flow, so maximum flow, the patient is being fully oxygenated is achieved, and I can check that using my machinery, my CDI monitor, looking at my arterial and venous gases, and I respond back to him full flow, and I'm happy. And at that point, the anaesthetist can then turn off the lungs. So very quickly, so the consequences of bypass. So bleeding, there's neurological effects, there's impacts on the kidney, possibility of lung injury, cardiac dysfunction. All these are whole lectures in themselves and massive topics. But the things you need to remember is the circuit is a foreign surface. And while it does a job, it's also not great for the patient. And whatever you have with the heart-lung machine, there's always a yin and yang, there's always a positive and negative. But you get kidney injury because the circuit is, especially if it's roller pump, it's non-pulsatile flow. So normally you have systolic and diastolic, and that's what the body of the kidney is used to. And it doesn't actually like not having that. So for a long bypass time, you can, if you don't have that, the kidneys do start to suffer. You have microemboli, you do have that hemodilution, you have stresses, and can see pink urine because the stress is going through the roller pump and so forth. We go on to talk about inflammation, you have coagulopathies, you have platelet activation. So all these things can eventually lead to organ injury, injury to the heart if the heart isn't given enough cardioplegia and protected sufficiently. You can have brain injury if the brain isn't oxygenated sufficiently. So the list can go on and on. But I think what I'd like to, after telling you about, what the patient has gone through, like from a cardiopulmonary bypass point of view and putting the circuit together, I just want if you ever see a patient on the unit after they've had an operation, have an appreciation what they've gone through. So if you had a patient on the unit that has a low hematocrit, think about what's going on, think about what they've been through. So they've had hemodilution. So if we've got a 100 kilo patient that's had an extra litre and a half of volume from the heart-lung machine, it's probably not an issue. However, if you've got a little 60 kilo patient, somebody like myself, that's had a litre and a half, it's going to have much worse effect, especially if your starting HB, is 10 or 100, whatever denominator you want to use. When that patient goes on bypass, you're going to have a hematocrit or of 21 or HB of 7. So one thing to think about is actually if this patient's got a low HB, do we need to filter them? Do we need to encourage them to either pee? Are they peeing by themselves? Do we need to give them diuretic to correct themselves? Or do we really need to give blood? The other thing, like I mentioned earlier, is if, again, this patient with a low hematocrit, has the patient been cooled? Look at the notes. Has the patient been cooled? Is the patient bleeding, or for example, bleeding because they're not warm up, they haven't been warmed up properly? This is something that people fail to think. The automatic reaction is to let's hang up a bag of blood and it'll all be fixed. But actually, you need to make sure that the clotting cascade is working. So one is making sure the patient's warm, and the other thing is doing things like thromboelastograms to check that the platelets and the other clotting components haven't been damaged. So it's really important to think about the patient's been on bypass, what's going on. I mentioned earlier about fluid shift. So how's the patient, this patient with low hematocrit, is it because they're really edematous? Look at the patient, feel their legs. So unfortunately, there's not an awful lot we can do about that. Some patients tend to be leakier than others. But if that's the case, can we again give them some sort of diuretic to correct that, so on and so forth? And then finally, I suppose the last thing in that thought process is the patient bleeding, and is that because it's proline deficiency, or is that because there's been excessive use of cell salvage? Now, I'm not sure who's seen a cell salvage or not, but a cell salvage is a wonderful thing that collects lots of blood, washes all the clotting factors off, and what we do is give back basically the patient's own blood back in a unit. So they'll get 200 mils of red blood cells, of their own red blood cells, which is great. The downside to that is it does wash all their clotting factors off. And what often people tend to forget is when you give cell salvage blood, you also should give clotting factors. So very basically, I hope I can give you an overview of what a heart-lung machine is, what it does, how it can support the surgeon, how you put it together, and giving you a view of what happens in theatres. But for the patients that come out of theatre that might not have seen before, when you're treating them, think about what they've gone through, think about what the heart-lung machine has done to them, and then take decisive action. And that's me. Thank you very much.